Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. Today's topic is about safe supervision of non-doctors and the safe use of standing orders. My name is Dr. Sam King and I'm a medico-legal consultant with MPS, and I'm joined today by two of my fellow medico-legal consultants. We've got Lucy Gibbard, who's a GP in Taranaki.
Hi, Sam.
And we've got Tim, who was a GP in Wellington.
Hi, Sam.
Nice to have you with us, Tim. And Lucy. So it's going to be an interesting discussion today, I think, because there are some questions that you perhaps have as listeners and that we have that we're not quite sure of what the answers are, because a lot of the things we will be discussing are fairly new to New Zealand. With the introduction of physician associates and paramedics into the GP team, we've had a number of calls from doctors asking about their risk in being supervisors. Other calls we receive are from doctors who've been asked to supervise cosmetic nurses who work independently but require supervision. So what are the risks and how can we do this safely? Tim, can I just start with you? Let's talk about physician associates to start with. They've been around for a very long time in the USA and Canada, but this is very new to New Zealand. So what is their training and their role?
Well, Sam, you started with a fairly complicated question right at the start, because, part of the problem that we have is that there are so few physician associates in New Zealand at the moment. I understand there are only about 30 or so. And then the other difficulty is that they seem to have different training depending on where they train. Predominantly it's in the USA or Canada, but there seem to be different programs for different areas. And we certainly know of some physician associates who have been trained up, for example, to just do colonoscopies in the United States. That's all they do. My understanding, or our understanding, is that they first of all do a bachelor degree, and then they have to do about 2,000 to 3,000 hours of hands-on medical work before they then enter a physician associate degree program or a postgraduate degree diploma. So if we look at the New Zealand Physician Associates Society website, it states that PAs, as we might refer to them, practice medicine in collaboration with and under the license of their supervising physician or physicians. And the scope of practice that a PA might have depends on where they practice and also, of course, what the scope of their supervising doctor is. Because, of course, although it looks like most of the PAs in New Zealand are in general practice at the moment, that's not necessarily what will be happening in the future. So on the website, they list a number of competencies that PAs can have, and starting off with obtaining a medical history, being able to order and interpret tests. Now, actually, in New Zealand, they can't order tests because they're not registered health practitioners. So that's something that they can't do in New Zealand. Diagnosing problems and then managing acute and chronic conditions. Overseas, they can also do things like prescribing, referring for specialist care, performing minor operations, and also managing inpatient care in hospitals. So their competencies overall are clearly much greater than what would actually apply in general practice. They're pretty well trained, it looks like, but the difficulty is knowing exactly what the training has been and exactly where their competencies are, which is the problem for those people employing them and what is then needed.
Totally. I think that because PAs have been around for so long in North America, I'm sure they're very confident in what they are able to do. But the difficulty comes, as you say, is with the supervising doctors, the uncertainties that we have around what they are in fact able to do and competent to do. Quite the dilemma. But if all of those things are true that you were saying, and that's on their website, it does sound like they can really help reduce the load in primary care and in hospitals for that matter. And whilst they are not regulated, Lucy, what does that mean for the GPs who work with the PA?
Yeah, well, I understand they're trying to get regulated, and obviously so this is the current situation while they're not regulated, but they are trying to get regulated, so it might change things. But currently, if you're working with a PA, the doctor who is supervising them is basically taking full responsibility for the work of that PA. And like any clinician, all PAs will have some strengths in their knowledge base and maybe some weaknesses as well. And if you're working with a PA, until you're aware of the specific competencies of that particular individual, it's really wise to closely supervise their work until you understand what their competencies are and you're confident of their skills. So that might mean you're going to be sitting in on consults to start, and you sitting in on theirs and them sitting in with you, reviewing each patient that they see, auditing their files, looking at the work that they've done and making sure that actually it is being done to a competent standard, which actually sounds like quite a lot of extra work, but this phase might not be very long if actually you're assured that they do have competency. Obviously, because they're unregulated, currently in New Zealand, they can't prescribe or order tests. They need a signature from a doctor to do that. And look, the temptation is to have the PA write the script and you sign it, or propose a medication which you accept, and then it becomes a rubber stamping issue for the GP. But that there is significant medical legal risks in that situation where actually the GP becomes responsible for that prescribing or ordering of those tests and following up the results. So the GPs have got to be aware that they do hold responsibility when they do that. And reviewing results is another consideration. Look, we know there's lots of situations where GPs are delegating inbox review to lots of people. It might be nurses or medical students, where they're filing some inbox documents. And that's a whole nother podcast of inbox management. But with a PA, there is an expectation that they'll work almost independently. But again, you've got to think it's coming down to the doctor's assessment of the level of competence of the PA as to whether or not they can deal with the inbox without supervision. And there are clearly some significant risks there because the buck will stop with the GP who is supervising them. So any decision that PA makes is essentially going to be held the responsibility of the doctor who's supervising them.
So Lucy, for GPs who delegate the responsibility to clear their inbox, I'm assuming that virtually all of them would have some kind of protocol in place and guidelines so that, let's just say, a med student would have very strict instructions about these are the sorts of things that you can file, these are the things you need to leave in my inbox, all of those sorts of things. Can you foresee that that's what you would need to do for a PA?
I think med students is a slightly different situation because there's that whole issue of are they acting as doctors before they've got registration. So I think we probably shouldn't go there in this podcast because there is a view held by some that medical students shouldn't be filing anything. They can look at things and write comments or help, but they can't really take responsibility either. They're not registered, and it's very clear the medical council don't want them to be acting as doctors before they're doctors. But in the situation of a PA, yes, you should have really good protocols and auditing systems, and it's different from getting another regulated health professional to look at your inbox. So there are some practices out there where they're using doctors to look at the inbox, and obviously in that situation, the doctor who files the results is responsible for doing that. Whereas if you have a PA looking at your inbox, they can't be held responsible because they're not regulated. So actually it's likely that the supervising doctor is going to be held responsible. Although having said that, it's so new, we haven't really had an awful lot of experience to see what outcomes would be in those situations.
Digressing just a little bit, talking about inbox, some GPs do ask their nurses to have a look at their inbox. And nurses are regulated, of course. Mm. But how much responsibility does the GP carry in delegating that responsibility to a nurse who's normally that would not be within their scope, I wouldn't have thought, to file a whole lot of results?
Yeah, I think if you've trained the nurse, if you've got really good protocols and you're saying, well, look, you're only filing normals and you're not, there may be situations. I think never say never with those things. Yes, you have to be very tight in the control in that situation because the GP may well be held responsible for that delegation. But having said that, a nurse is a regulated health professional in their own right. And if they're working appropriately within the bounds of their delegation and their competency, then they can be held to account for their own decisions.
And like any health professional, they're expected to recognise the limits of their competence and to not go beyond that. So that does create a significant responsibility on the nurse who's looking at the inbox.
And it may be the practice in that situation that would be held responsible if they have protocols that allow that to happen, and then the protocols are deemed to be, not offering a safe level of care.
I think for any clinician, what's important is that you know what you don't know. Because if you know what you don't know, then you can be safe because you can ask. I think for us, it's when we don't know what we don't know that we run into trouble. And that's for whether you're a regulated doctor, PA, whatever sort of clinician you are. So, yeah. Tim, how would the HDC view a case if a PA advised medication that the GP signed and the patient had a poor outcome? Who do you think would be held accountable? Now, I know I'm not aware that we have any cases, but just in that short scenario I've suggested, how do you think the HDC would respond?
Yeah. Well, you have this kind of dilemma, really, in that you've got a highly qualified physician associate who's capable of making all these decisions, competent to do it. And so, I think as Lucy's alluded to, that there's going to be a temptation to just allow them to get on with it and do it because you need their input. And it's likely that the supervision levels will drop off significantly once you have experience of their competencies. But because they aren't able to work independently, because they have to be supervised, I think the HDC is going to look very closely at the GP and say, ultimately, look, you are responsible. You are the one who's supervising. This is an unregulated health professional who's working in your practice. You have that responsibility. And I suspect the HDC would not deviate from focusing on the GP and that line of supervision responsibility.
It will be interesting once a few cases start filtering through to see exactly what happens down in those sorts of circumstances.
There's also the question about whether ACC would apply. So is this a treatment injury if it's a non-regulated health professional who has, in effect, created the injury? And look, I don't think we're clear on the answer to that. It may well be that ACC would decide, well, look, because of the supervisory requirements, actually it really is the GP who's making these decisions finally, and therefore it is a registered health professional, and therefore ACC does cover it. But I don't think we've seen any examples to be able to comment.
No, we haven't. I suspect ACC will see it as the GP having provided the care in an attempt to make sure the patient does have cover. But you don't know until it happens. You don't know until it happens.
And you'd certainly hope so. Though we have seen examples where ACC have tried not to accept responsibility where they possibly can, and cases that have had to go all the way to the Supreme Court before the courts have finally decided, yes, actually, ACC does have responsibility. So, it may require a little bit of legal work before it's finally established.
That's a watch this space one, isn't it?
Mm-hmm.
It's not very comforting for the employing GP, though, I'd have to say, not knowing whether ACC kicks in.
What, as in being concerned that they could be sued? Yeah.
Yeah, and that's why it would be such a complete anomaly in the ACC system that you'd think that no, the courts couldn't possibly allow that to happen. And just as the recent cases regarding non-diagnosis of spina bifida on antenatal scans, which did go to the Supreme Court, the court recognised that no, you can't have an anomaly whereby certain circumstances suddenly there's no ACC cover and therefore an individual provider is responsible.
But it did take going all the way to the Supreme Court. Okay. So shall we move on and talk about paramedics who are registered now in New Zealand, and some are working as part of the practice team in primary care. Lucy, do you know what is within a paramedic's scope?
Well, according to the Paramedic Council notice, the paramedic's scope is primarily in the provision of urgent and or emergency assessment, diagnosis and treatment of patients, including provision of clinical advice and referral. So there are paramedics who hold the basic qualifications, and there are also extended care paramedics who have completed postgraduate qualifications focusing on primary care. And the extended care paramedics do have additional skills such as suturing and maybe prescribing of antibiotics, understanding orders. So in general, their scope of practice is urgent and emergency care rather than management of chronic conditions.
Are you aware of any practices who do have paramedics and whether they are seeing patients with chronic care matters?
I know of many practices that are using paramedics. I'm not sure exactly how they use, because I think in general they're trying to use them for acute care,
which makes a lot of sense.
And triaging. But I don't know is the answer to that.
Tim, how does supervision of a paramedic differ from that of a PA or safe supervision? What would be the difference?
Well, the critical difference, of course, is that because they're registered, it means that they can work unsupervised within their scope of practice. So the supervision requirements are very different. And because they're registered health professionals, they would be expected to recognise their own level of competency, as we've talked about previously. The problem, though, would be for a practice that didn't adequately know and be confident about the levels of experience, expertise that a paramedic has, that if anything went wrong, then that would be looked at. And, with the HDC, a practice can be found both directly and also vicariously liable for the actions of an employee or an agent working within the practice. So I think it would be very prudent for employers to ensure that every employee is working within their level of competence, and that, as with a physician associate, may well take time to work out just exactly what your paramedic can do without needing direct kind of contact and what you can feel confident that can do without you being involved.
So in some ways it's similar, having a PA and having a paramedic.
But it's different because they're regulated and they can work unsupervised.
They can work unsupervised, but in terms of needing to find out the competence or level of competence of the individual clinician that you've got working for you.
Yeah, so with the physician associates, it's going to be the individual doctor who's supervising, who's going to be directly in the line of fire, if you like. Whereas for a paramedic, it'll be the practice as a whole to look at whether they've adequately assessed the competency.
And I assume that there'll be an onus on the practice not to assign the paramedic duties that fall outside the scope of practice, as in the urgent and emergency so that will become an issue. I can imagine with the HDC, if there was a complaint or an adverse outcome.
I would have thought there's a high onus on the paramedic themselves to know what their scope of practice is and to work within it.
Yes, and that's always an interesting discussion with a complaint with the HDC when you're trying to work out that kind of thing. At least we do know that there's no question around ACC cover. Because they're registered health professionals, then their actions are covered.
Lucy, you mentioned before about standing orders. Would you mind just explaining what this is and how it works?
Yeah, and I think they are out there and they're often not followed in the way that it should be. So look, a standing order is a written instruction which is issued by a medical practitioner or a dentist, nurse practitioner or optometrist. So essentially by someone who's got the right to prescribe. And it authorises a specified person or a class of people, such as paramedics or registered nurses, who don't have prescribing rights to administer or supply specific medications and sometimes even controlled drugs. And the idea of standing orders is that to improve the timeliness of patients' access to care or medication. So, for example, by authorising a paramedic in an emergency or a registered nurse in a primary healthcare setting to provide a patient with, paracetamol or an antibiotic or something like that under specific situations. But the standing order doesn't allow that person to generate a script and provide it to the patient and take it to a pharmacy to be dispensed. Pharmacies can't lawfully dispense unsigned scripts. And the standing also doesn't allow that person to provide a patient with a prescription that has been pre-signed by a medical practitioner or a dentist. So basically, they're used by paramedics and who are called out in emergencies, but they're also used by nurses in primary care in nurse-led clinics. The problem is that we all know that there are standing orders and they are frequently used in general practice. However, the guidelines are so prescriptive and the responsibility falls so hard on the doctor or the nurse practitioner who's signing them. And that prescribers' obligations are that they have to ensure that the legislative requirements for the standing order are met. They have to ensure that anyone operating under the standing order has appropriate training and competency to fulfill their role, which is a big ask. So when you're signing a standing order for a nurse to prescribe trimethoprim for a UTI or something like that, you have individual responsibility for that nurse's competence for that particular action. And then they're also either required to countersign every single episode where that medication's been provided, or they have to do, I think it's monthly audits, isn't it? It's some audits, hugely onerous system whereby you have to actually oversee that the use of that medication. It's really worthwhile reading the Ministry of Health guidelines on this. There's a really good document on how to set up a standing order and all those things. But when you read it, you do realise that an awful lot falls on the doctor who signs it to be responsible, one, for making sure every single use of it has been reviewed or audited, but also that the people using it are competent. And sometimes that's hard.
I think it brings into question whether it's wise for a doctor. As we know, there are many practices now where they have different clinical sites, and some of those can be very big organisations. So if you've got, say, a clinical director who sits in the main office signing standing orders that go out to all of their peripheral clinics, it would be very difficult, if not impossible, for that doctor to ensure that each of the staff are trained appropriately and competent to do that. And you wonder about audits, how they're even able to do that.
The audits can be done on paper, so you wouldn't need to be sort of directly on site. But I agree that the problem will be in the initial assessment to make sure that each person who is providing that service does have the skills to do it. Now, it may well be that a clinical director can delegate that authority to a GP or nurse practitioner who's in that particular clinic, and provided they have the skills to assess the nurse to make sure they're competent, then that would be fine. So I think it can work in a big organisation, but it just would require a lot more kind of logistical care, really, if you like, in the process.
I just think the time requirement for auditing monthly is unrealistic in today's primary care settings. There's so little time anyway. The idea of sitting down to audit every nurse's standing orders every month. So our practice, for example, if a nurse ever uses a standing order, they have to generate a task to the doctor who then has to countersign it on the time. So we do countersigning of every standing order rather than having to audit, because we decided that was probably... And
that may well be quicker, that's
right.
right.
We decided it will be quicker.
But there may be some organisations where there are lots and lots of use of a standing order, and in that case, doing an audit may be better, and there are guidance in those guidelines as to how many cases you need to look at for an audit, and that's dependent on the number of users there are of that standing order per month. And I think if it's, if you're in the sort of 500 to 1,000 users per month, then you only have to order 5 to 10% or something like that. Yeah. But if you do find anomalies where the standing order hasn't been properly complied with, then you need to start auditing more to see how widespread that anomaly might be.
Yeah, I think family planning uses an awful lot of standing orders, don't they? So they probably do the auditing system.
Yeah, and they would have lots and lots of the same sort of thing over and over again. Yep.
Yeah, I am aware. I've had at least one inquiry where the doctor who signs the standing order virtually doesn't even know the staff in the other clinics. And because of the lack of doctors, they don't have any doctors on those sites necessarily. So a lot of these nurses, for example, are working completely independently, which does make it a little difficult if you're working with standing orders. I thought it was interesting, Lucy, you said before that standing order doesn't allow a person to provide a patient with a pre-signed prescription by another doctor. I'm aware that that happens as well. So it's interesting that you can't do that in the guise of a standing order. Probably very useful for our members to understand that. Tim, did you have a recent inquiry about standing orders?
You would get the odd one, and this was a very specific one because it related to advice actually to pharmacists, and so that raised questions about whether this was really a standing order or not. And it was also around the use of medications off-label, and whether that could be done under a standing order. And so we got the lawyers involved because that was certainly something that I had no ability to make any decision of. And they looked carefully at the regulations and kind of came back with a careful response that they couldn't find anything that would suggest that it wasn't okay, which is slightly different from saying, yes, it's definitely okay, but at least, partially reassuring. But this was certainly a circumstance where having anything different would have been really tricky for the doctor to try and manage in that situation. And so being able to give her at least some reassurance that it was probably okay was certainly beneficial for her.
Mm. And it might be that in the end, the doctor might need to approach the ministry themselves with an inquiry and just confirm whether the situation was okay.
Yes.
Whether you get an answer or not is another matter.
Yeah.
I actually approached the ministry a wee while ago about the fact that, each individual doctor has to sign every standing order for every individual standing order. And so in a big practice, you end up with files and files and files, and they have to all be signed every year. And so whether we could have a single standing order for paracetamol that 14 doctors signed, or whether we had to have 14 separate standing orders for each doctor. We never really got an answer, but, in the end, everyone signs it. So hopefully it's all right.
That's right. Each standing order has to be reviewed.
Annually.
At least annually. And as you say, signed by every doctor.
And signed by every doctor.
Yeah, that's a lot of signing.
It's a lot of signing. Yeah.
So we do get inquiries from members who have been asked to supervise and provide standing orders for nurses who essentially work completely independently in, say, a school or a cosmetic clinic. And often the doctors have never even worked with that nurse before. Lucy, what concerns would you have in that situation?
Well, I think we've kind of touched on some of those before in that, if it's not someone you're working with, how are you going to reassure yourself as to their level of competence? Because it's your responsibility. So that's something to consider. If it's someone you're not working directly with, how are you going to ensure that they're competent? And also, if you haven't got a relationship with them or you're not working with them on a day-to-day basis, often that actually impedes the communication, which can make it very difficult if there's an issue or if there's problems. And then the accountability and trust in that situation is also very difficult for the doctor. In the situation where you're essentially putting your neck on the line, saying, I will be responsible for this. If you don't know the person you're doing that for, then actually that can be very difficult because you're going to be responsible for all the medication that's given under the standing order. And obviously, nurses can, the nurses who are well trained and completely appropriately able to dispense the medications, and you can train them to recognise the reactions and how to manage that and all those things. But if they're working remotely, how do you do that? And how do you ensure it's been done? So I think it's just more difficult, but it's not impossible. But it's the level of trust has got to be higher, and probably you have a higher obligation to have some system to make sure they are competent.
Yes, because the level of responsibility of the supervising doctor is still there,
Yeah.
no matter how remote and how little contact they have. And so, for example, the HDC, I wouldn't imagine would take into account the fact that the doctor didn't know the nurse very well, and therefore it was okay for something to happen. That really
I don't think that would be
No,
the approach, no.
I think the main thing would be that if you've been asked as a doctor to supervise and sign standing orders, that look, most of the time, probably 99% of the time, everything's going to be fine. But that's that 1% that can turn around and bite you. And so there are probably certain things that you can put in place to ensure that the nurses are safe, you're safe, and of course the patients are safe. And so I think we've really touched on those things, haven't we? You just need to take the time to do that, ensure competence and make sure there are good lines of communication, accountability and auditing and all of those things so that you can sleep at night and without the worry of that HDC letter coming through your inbox.
So Lucy's already mentioned the Ministry of Health guidelines on standing orders, and certainly I think that's a must for anyone who's entering into any kind of relationship involving standing orders, that they look at that very carefully, because as she's mentioned, they are pretty prescriptive and pretty onerous as well. And so anyone going into it without doing that very carefully would be certainly putting themselves at risk. And there's the countersigning or auditors, as Lucy has mentioned. Fortunately, the guideline also does have a really handy checklist to go through to make sure that you do actually meet all the requirements for a standing order. And it's also got a template in the guideline for setting up a standing order. So there's help as well as sort of warnings, I guess, in the guideline. But yeah, that's the bottom line, is that that's the document that needs to be adhered to.
That's great. Thanks, Tim. So let's just draw this all together and talk about the take-home messages. So we've got the physician associates that have recently entered into New Zealand. So they're a new type of clinician, but there are ways to work with physician associates safely, as in the same way that we can work with paramedics safely. And it's really just about being aware of what the potential issues are and making sure that you have systems in place and structures so that you're ensuring that they are competent to be able to work within their scope of competence as well as within the scope of practice that they have. And that's the same with standing orders. Lucy and Tim have helpfully talked to us about standing orders and the ways that you can protect yourself to ensure that we've got in primary care people who can help and take the load off without increasing anybody's risk. So thanks, Tim, and thanks, Lucy, for this afternoon's podcast. And thank you for listening to this podcast as well. I hope it's been helpful. Our next podcast will be talking about whether you can be a good Samaritan and what are the risks and obligations of that. And we hope that you'll tune in for that. We look forward to catching up with you next time. If you like the Medical Protection podcasts, please subscribe and leave a review. And if you would like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org. Thanks, Tim, and thanks, Lucy.
Yes, Sam.
Thanks, Sam.